So I'm going to discuss pediatric cataract management in age more than 8 years. Pediatric cataract in age more than 8 years are usually congenital with delayed presentation or the juvenile cataract, which develop after infancy, and these have good visual outcome after cataract surgery or the other acquired cataracts. Juvenile cataract present with myriad of morphological pictures, and surgical planning is often based on the morphology. Traumatic cataract and the uveitic cataract are important acquired cataracts. The indication for surgery in older children is size more than 3 millimeter, a distorted retinoscopy reflex, vision less than 20 by 40 if the patient has problems in the classroom. Here is a picture of a unilateral anterior polar cataract with vision of 20 by 25, and no surgery was indicated in this case. The objective of surgery is to clear the visual axis by removal of the cataract and focusing of retinal image by placing an IOL plus minus glasses. The problem is that the eye is small, the anterior capsule is elastic, the scleral rigidity is low, there is increased vitreous pressure, the anterior chamber is unstable, and there is difficulty in calculating IOL power. Surgery is therefore technically more demanding, and post-op inflammation is high. The younger the child, the more marked are the differences. The infrastructure required are the equipment for the IOL power calculation, like the A-scan and the keratometer. Handheld keratometry is only required if we are planning under GA. Children more than 8 years cooperate in biometry, and therefore IOL power can be estimated prior to surgery. Formula found to be more predictable are the Holiday 2 and the SRKT. Method of choice is the optical biometry or the immersion biometry. Of GA backup, cutter, and microsurgical instrument are required. Anesthesia in older children, local anesthesia can be given in cooperative children, especially in the developing countries where GA is a big problem. Cooperation can be judged while doing the biometry and other procedures in the OPD. Globe size is bigger as compared to the orbital volume in pediatric population, so peribulbar block should be given carefully. The other option is LA with sedation and general anesthesia in mentally retarded children or very cooperative children. Now, ketamine has become a very popular anesthesia in this pandemic situation. In all the cases, we have to put an intracath and also prepare orally if sedation is required. Surgical steps include incision. The main incision can be made limbal, scleral, or clear corneal. Side port incision can be made by an MVR blade or a side port blades. The anterior capsular axis is usually done manually by Rexis forceps and micro-Rexis forceps. The other options are Vitrorexis, Clotis, radiofrequency, diathermy, Hugo blade, Femto, and Septo. The manual CC is different from the adult in the fact that the force is, the pull is towards the center. Trypan fluid staining helps in visualization of the anterior capsule and decreasing the elasticity of the anterior capsule. Cohesive viscoelastic is important because they help in flattening the anterior capsule and helping in Rexis. So here I'm showing you a case in which I'm doing anterior capsular Rexis. My video is visible. Okay. So I'm using a micro-Rexis forceps, and it has got markings on the forceps. And actually, you can measure the size of the Rexis using this micro-Rexis forceps. The technique is grasped and re-grasped, and the pull is always towards the center. A small Rexis of 5 to 5.5 millimeter is a good Rexis, and smaller Rexis will cause phimosis, and larger Rexis will cause IOL dislocation or IOL optic capture. So this is another case of a total cataract, and here the Rexis is very difficult. But since we are using the proper technique, we will be able to complete the Rexis. The advantages of using a manual Rexis is a good beam strength. There is lesser chances of radial tear during IOL insertion, lesser chances of decentration, and it is considered as a gold standard. The disadvantage is it is not possible when the capsule is fibrosed and there is a learning curve. So a good hydrodissection ensures good cortical cleanup. A 2 ml syringe with a 30 gauge cannula is being used. Multi-quadrant hydrodissection is done, and it is used to break the cortico-capsular adhesions. Usually by the end of the hydrodissection, the nucleus is prolapsed out, and it should be avoided in posterior lenticonus or posterior polar cataract. Cataract removal can be done manually by using the AC maintainer or by automated method like the coaxial or the biomanual. The biomanual offers better chamber stability, and the cataract is so soft it can be easily removed. But the cortical removal is a very important step, and it has to be done very meticulously. All the fibers of the cortex have to be removed, and PC polishing has to be done adequately. Otherwise, there will be a very high-grade post of inflammation, and also there can be a risk of PCO. So here, sometimes we do get this type of picture in which we find a PC plug sitting on the posterior capsule, and we have to peel this. Using the retro illumination of the higher-end microscope helps in these cases. We are cutting these attachments and then peeling from the other side. This type of plaque cataract are quite frequently seen at my center. And then we have to rotate it and take it out. So sometimes this is a thing we can see. This is a posterior capsular dehiscence, grade 2. And for these cases, we have to keep a cutter backup. And so here I'm doing a bimanual vitrectomy. Also, in cases like this, where there is a dense fibrous membrane, we have to do a vitrectomy. So vitrectomy, bimanual vitrectomy offers better chamber stability. Pneumatic cataracts with high cataract are better. Venturi pump is better than peristaltic pumps, and we have to ensure lesser dispersal of vitreous in the anterior chamber, and we can use preservative-free triamcinolone. The intraocular lens, which can be put, are the hydrophobic acrylic, which is a good lens, and a single-piece lens we can put in bag. And if we are planning a sulcus fixation, then we have to use a multi-piece IOL. The age group of 8 to 12 years of pediatric patients are a good candidates for multifocal IOL. The pros is a spectacle independence, but the eye is a growing eye, and myopia in teenager can be expected. We had many secondary refractive surgeries. The cons are halos and glares, less common in more recent design, more sensitive to tilt and decentration, decreased contrast sensitivity. These problems are less common in modern designs, but it is an expensive lens and more prospective trials are needed. The closure of wound can be done with a 10-0 monofilament or a 10-0 vicryl. Advantage of using a vicryl is that it gets absorbed and there is lesser suture-related complications. The post-op care we have already discussed, and actually pediatric cataract surgery is a challenging surgery and it requires a good teamwork, counseling, pre-op and intra-op, post-op. But the social impact is huge, and there is decrease in daily, increase in life expectancy, and positive psychosocial impact. With this, I come to an end by a quote, intelligence and capability are not enough. There must also be a joy of doing something beautiful.